I always like, we've just come from the ASH meeting, we've had several days of new data, excitement, discussions. I want to go down the list and give everyone, or the table I should say, and give everyone maybe, a minute and a half, 2 minutes, just to give your key, and I'll start with Alexey in a second, the key take-home points from ASH, new things you learned that people at home in their offices need to know about as they approach patients, things you're excited about going forward in Mantle Cell. Your thoughts?
Yeah, I think the excitement is around novel therapies, for me at least. I think we are entering a new era where novel therapies potentially might even replace chemotherapy agents, DNA damaging agents in certain subtypes of lymphoma. I think the follow-up to ibrutinib data looks very interesting. The new acalabrutinib data looks very good. And I think in the future we need to figure out how to use those drugs combined with chemotherapy in an upfront setting, or combinations in the relapsed refractory mantle cell lymphoma, and whether we do need to use them indefinitely or can stop at MRD. There's going to be a lot of questions to be answered through clinical trials, and I think it is important to enroll patients with mantle cell lymphoma in clinical trials, like John said. Rare disease, and we need answers.
Steve?
Yeah, so I mean, I think two strong messages that I got from this meeting. One was that in mantle cell lymphoma, progression-free survival is important, and it tends to correlate with overall survival. I know there was the data can be criticized being retrospective, and there was some heterogeneity between those that got transplants and didn't, et cetera. Bottom line is, it's one of a number of studies now that show that in mantle cell lymphoma, PFS can translate into OS, and that's not what you see, for example, in many of the follicular lymphoma studies. So I think you, at least outside the setting of clinical trials, even using the older chemotherapeutic approaches that are intensive and may or may not or use an auto transplant, it's important to try to get to as deep as remission as possible, because that'll lead to the longest PFS. And again, as we move forward into the era of novel agents, we can exploit them. The second message is, once you've had that long remission, okay, your next treatment should probably not be chemotherapy, because patients who have more than one chemotherapy exposure, when they go on to kinase inhibitor, have a markedly inferior duration of response. So I think you have to look at ibrutinib, acalabrutinib, outside the setting of a clinical trial as your next step. And I don't think there are long-term solutions for the relapsed patient, okay? But, and hopefully someday it will move up front to a non-DNA damaging regimen. We'll have even longer PFSs, and we won't be in that situation.
Yeah, I was very much struck by how BTK-centric the meeting was. I think that mantle cell is moving in that direction. We've got more and more data with ibrutinib. We now have acalabrutinib. There are a few other agents out there which may or may not have important differentiating features, but it seems likely that more people are going to get a BTK inhibitor up front. Relapsed, it's certainly moving up. These combinations are coming along, and then BTK resistance is going to be really a crucial thing as to what will work in those patients with resistance. So I think that's something with respect to mantle cell that really struck me as being important, that we need to keep working on. How do we use these drugs most effectively? How do we stop them also when if patients can go a treatment-free interval, but also how do we combine them, and perhaps a shorter duration in combination will lead to treatment-free intervals that'll be better. So, Andre?
The mere fact that we're having all this excitement and all these data is actually thanks to clinical trials. Yeah. So I would definitely encourage our audience to refer patients and participate in clinical trial to answer these questions. Take-home message from ASH, greater optimism in mantle cell lymphoma. We are in a period of transition where we are starting to learn on how to combine or try to combine with chemotherapy. We are starting to do window before chemotherapy, and I'm convinced, as I alluded to before, we're going to do combinations, particularly small molecules and venetoclax and obviously BTK inhibitors that seem to give really high response rate and molecular CR that might hours to start to develop non-chemotherapy option in that setting. What is going to be also really important is to try to identify, as John alluded to, the mechanism of resistance, and so that we can identify what's the best sequence, and alternating maybe some of these biological agents until we reach a deep response enough to have a durable outcome. One caveat that I just want to highlight is that we tend to think chemotherapy is over. I think it took us 20 years to make some progress in mantle cell lymphoma, so I would not just throw it away immediately. I would just try to make sure that we have the proper combination. And then finally, immunotherapy, which was the big thing of ASH, will definitely also apply in mantle cell.
Okay. John?
Yeah, it wasn't fair that you started at that end.
Wow.
So actually, I might say something a little different and extrapolate from what we've learned about the use of CAR T cells in large cell lymphoma at this meeting and where that will play in for mantle cell. Sure. I am very enthusiastic about this. Steve's data is incredibly impressive. I thought that the data presented by Jeremy Abramson on his large cell lymphoma patients was also quite encouraging using CAR T cells from two standpoints. Difficult patients getting complete remissions that are durable, and the cytokine release syndrome rates as well as the neurotoxicity rates being much more manageable and acceptable, and then the future of this as a potential outpatient therapy of course, going to be critically important. And I don't think there's any reason that we can't think that these kind of great, exciting results in large cell won't get translated to mantle cell.
They do apply.
And I think that's incredibly exciting. And I hope next year when we do this, we're talking a little more about the data for mantle cell with CAR T cells.
So I think it's also, and I think we want to also emphasize the news for patients. I mean, this is great news for patients, and I was impressed by what you said earlier that resonated with me, the perspective that anything that we talk about or any of the data ends up being, the long-term data ends up being retrospective, because basically anything with 3 or 4 years of follow-up is really a study that's reporting a regimen that we don't use anymore. And I say that to patients all the time, that anything you read about your prognosis in mantle cell doesn't take into account what has happened just in the last year, and it's incredibly challenging for people in practice to keep up with it. It's hard for us to keep up with it.
And for patients, there's a lot of negative stuff on the internet, which is dangerous.
Yeah. So I think it really highlights the fact that there is a lot of progress happening, a lot of optimism, and I think mantle cell is not what it used to be for patients in prognosis, and hopefully we can continue to make progress and have patients have better and better outcomes. So I want to thank all of you for joining us today. This has really been a great discussion, a great recap. I always love hearing different people's perspectives. I think we agree on a lot of things, but we disagree on a lot of things, and we always learn. And I think that's a reflection of the disease. It's a reflection of mantle cell in general. And I think this is, I hope for the audience, really been kind of the state-of-the-art mantle cell biology, treatment, outcomes in one session. So it's been a nice program. So thank you all very much. And I want to, on behalf of our panel, we thank you very much for joining us today for this peer exchange discussion.